But the other mutations, the TCN2, FUT2, and MTR and MTRR, those are all B12 enzymes. Those are utilized in taking B12 from food, converting it into the actual B12, absorbing it into your system, and then once you have it in your system, you actually have to get it into a cell, because just B12 floating in the bloodstream doesn't really do a whole lot. The B12 has to get inside of a cell in order for it to work. So there's multiple mutations that can happen there. Then once the B12 is inside the cell, once it's used, it can be regenerated. And so one B12 molecule can basically be used multiple times before it's discarded. Well, if you have these MTR and MTRR mutations, then that means your B12 is kind of one and done. It's not adequately regenerated. And so there's multiple errors to have B12 problems along the way. And based on where your mutations are is where I'm going to recommend what type of B12 you need to be doing. Many people can get away with just taking more oral B12. That can raise the serum or blood concentration of the B12, and just raising the concentration sometimes forces it into the cells and gets it to work and really do what you need it to do. But that's another reason to have high homocysteine levels. There's a lot of people right now pushing methyl B12 because of the MTHFR issue, saying that if you have MTHFR, you need all methylated B vitamins. That is not true. You can over-methylate. Look it up if you don't believe me. Over-methylation is not fun. It triggers anxiety and just kind of creepy crawlies in the skin, not feeling good, not sleeping well. So over-methylation is a real thing. I don't see it so much with over-methylation of the folic acid vitamin, but certainly I've seen it with methyl B12 many times, taking too much methyl B12. So I prefer to take hydroxy or adenosyl B12 because that doesn't force the cycle into over-methylation. If your body doesn't need it, it just urinates it out, no big deal. If you take methyl B12, that's adding real methyl groups to the system that it can't always deal with, especially if you have other mutations. So depending on which mutations you have in your B12 genetics, we might be actually prescribing shots of B12 because you just can't get it into the cells, you can't get it into your system high enough, or maybe you've just got gut dysfunction. You need stomach acid in order to break off B12 from food and then be able to absorb it. You need something called intrinsic factor in your saliva and stomach in order to be able to capture that B12 and absorb it into your intestinal tract. And then if you have any kind of intestinal inflammation or malabsorption, you may not be absorbing the B12 there either. And so many times we'll use shots just because that's foolproof. Once you shoot yourself with B12, it's in the system. Now we just get to kind of dial the dose and how often. So B12 is a common problem I see overlooked instead of just forcing the folate cycle.